Hello, we are going to speak today about the decompressive craniotomy in children for trauma, for strokes, and other conditions. And in this first part, we are going to speak about the principles and the results of this surgery. So first, what is the rationale of decompressive craniotomy? It is basically to improve brain circulation. You know that brain circulation is ruled by the equation cerebral perfusion pressure is equal to mean perfusion pressure minus ICP. And we know that the children we are treating are placed at the right of this the Starling's curve. That means that the moment when the brain is most stiff. So there is an uncoupling of the volume and the pressure. And especially in children, we know that the curve is stiffer than in adults. That means that the pressure rise is all the more deleterious. And what we aim is to bring back these patients from the right to the left of the curve. So it's an emergency management of severe intracranial hypertension. It is a multidisciplinary approach, and we have to remember that time is brain. That means it is very emergent to decompress these brains. So when and why do we do the decompression? It is in case of refractory intracranial hypertension and there is no hematoma to evacuate or no CSF to drain. On the imaging, we have the very telling image of the obliteration of the perimesencephalic cistern. You see here on the left, preoperatively and after surgery, how the cisterns are restored. So we have to remember that in children, the window of opportunity is narrower when the child is younger. That means immediately in admission, it's important to do a transcranial Doppler. And when we manage this patient in ICU, it's important to insert the ICP monitoring on day 0 of trauma as soon as possible. And here you see the Doppler, which shows a very severe decrease of the diastolic pressure. Here you see that there is even a reverse flow. That means it is especially emergent to decompress. So, as I said, this surgery is part of the multidisciplinary medical response, which is graded with first opiate and benzodiazepine sedation, then the use of catecholamines to improve the hemodynamics, the use of pentotal and osmotherapy, all in very quick succession, because if there is a failure of treatment, we have to know it very, very soon to react as quick as possible. So this is the series we had collected in Lille. We did a craniotomy for intracranial hypertension in 37 children with trauma and 4 with vascular conditions. This is more than 40 in total, because one had a traumatic carotid dissection. In most cases, it was early surgery on day 0, D1 or D2, but sometimes later. So there were 40 children with a male predominance. The mean age was 9 years, but 3 of them were under 2 years, and we had a mean follow-up of 35 months. So the mortality and morbidity is as such. We had 3 patients died despite our surgery. So this is a small number compared with the number of children who were at risk of dying very fast. And about half of the survivors had a good outcome. And this is an example of a child who was operated very early, and on day 7 of his reconstruction, this is how he was moving. You see that his right arm is not moving perfectly well, but he's already using it and improving fast. So after surgery, we often have hydraulic problems. This has been the subject of a paper by Marie Manfiotto, who collected a cooperative study in France. We know that CSF flows better in a closed container. In some cases, we have hydrocephalus, which may require EVD or a valve in some cases. Or in some cases, we have subdural collections which have the untasty habit of pushing the brain outside the skull. So it may require a subdural drainage and sometimes a subdural peritoneal shunt. So, and also it may be a problem when we reconstruct the calvaria, because it may require a lumbar puncture or lumbar drainage before we can put back the flap in place. So what happens in the very young children? We had 3 cases under 2 years. All 3 were vascular cases. This is a girl, 21 months, who had a carotid artery dissection, which was operated on day 0. This is another case with an arthritis due to chicken pox, which was operated on D1, and another vascular case, which was an MCA aneurysm, which had a postoperative ischemia and required a bone flap on day 1 of his first surgery. And all these children survived, but all had sequelae, and 2 of them had extensive bone necrosis. One associated with healing delay, and one of these children required cranioplasty. So, is there a place for decompressive cranioplasty in shaken baby syndrome? I think the place is certainly very small, because when they arrive with a big black brain in emergency, we think it is beyond resource. Decompressive craniotomy would not help, and also these children are very unstable. And in other cases, in most cases, we can do a lumbar drainage or lumbar puncture, which has a very dramatic effect in the children. And the main problem in the children is to sedate them and manage the seizure, which is really the key for the survival. So when in the rare cases when we have to do a craniotomy for a subdural hematoma, we have to anticipate that the bone flap should be large, because it has a decompressive effect, and as you can see, and when you open the dura, it is under very high pressure. So we think that in very small babies with a shaken baby syndrome, what is most important is to monitor ICP very early, and have a very aggressive approach to sedation and hemodynamic management. So, as I said, bone flap resorption is a frequent complication in children, especially if we reimplant dead bone. That means bone conserved in deep freeze in the bank. In our case, 3 of the 7 children whose bone was conserved in the bank had bone resorption, and only 1 in 7 who had the bone preserved in the abdomen. So probably younger children have more often bone resorption than older patients. Maybe they have a higher bone turnover. So I think we should not use the bank. So then we have to think about very early craniotomy. As I showed, several of our children were operated on day 0 of admission. And we know that in adults, surgery is avoided on day 0 because the brain swells, there is a tearing of the draining veins, and it may be impossible to close the scalp if the brain is bulging too much. So it is not very popular in adult neurosurgery. However, in children, as I showed, 6 of our children were operated on day 0, and only 1 of them died. So we can consider that it can be a life-saving surgery on day 0. And but we can then ask the question is, can these children be operated even earlier? So this is a case of a 4-year-old girl who fell from a mezzanine onto the bone, onto the stones of the ears, and she had a trauma at about 5 p.m. And initially she was speaking to her parents. Then after 30 minutes, she fell into a coma, and she was admitted at 7 p.m. At that time, the transcranial Doppler showed hyperemia, and on the CT scan, we saw a depressed fracture, and we decided to do a reduction of the fracture. But we also anticipated to do a decompressive craniotomy. And this is how it went. When the depressed fracture was reduced, we found that the brain was under high pressure. So we did a bifrontal craniotomy with a replacement of the bone flap hinged on the metopic region. At that time, the brain was okay. And after opening of the dura, we had CSF under high pressure, after which the brain was much relieved. And we did a bifrontal duroplasty, and we put an ICP monitor which shows ICP was at 4 on closure. However, the story does not end there, because during the night she underwent a CT scan. The ICP went very high again, and she underwent a second surgery 12 hours after the first one. And then the ICP was very well controlled. She evolved very well because she was extubated on day 6 of the trauma, and she exit ICU on day 9. And I saw her very recently. At 9 months after the trauma, she lives a normal life. So she still has to be evaluated, but clearly, ultra early craniotomy was very beneficial to her. This is another example of a 12-year male who had immune encephalitis. He had event syndrome. That means that his platelets were very low, and he had progressive lesions. Then he developed papilledema. And when he was referred to us, he arrived in the emergency room on the 29th of December. He had a severe headache, somnolence. He had a CT scan which shows very severe brain edema with mass effect, and he was showing increasing somnolence. And we decided to do emergency craniotomy. He arrived to the OR at 5:20. The transcranial Doppler done just before surgery showed severe reverse flow, and he was operated at 5 hours after admission. This is how the brain was bulging after the surgery, and hopefully the ICP could then be corrected with the addition of an EVD on day 1. And he showed progressive awakening, and with the immune therapy he underwent, he recovered. So this is an example of the token die which can be prevented. The clue to this indication for surgery is the clinical presentation showing a rapid degradation with a patient who initially talks, then becomes comatose. So we should anticipate that these patients are going to show severe intracranial hypertension. The imaging shows that the cisterns are effaced. The temporal horns may be abnormally visible. The transcranial Doppler can be very useful in emergency, and the transmission should be fast and seniorized not to miss this opportunity. And we need, of course, to have an operating room available and willing to do this surgery. So the transmission chain is crucial. We have first the call for emergency service, then the imaging, then the ICU, ICP monitoring as soon as the patient arrives, and we have to decide very soon if the medical treatment fails to do surgery. But all this takes time, and in some cases we may need an earlier decision and take a shortcut directly from imaging to the OR. And in this measure, the transcranial Doppler can be very helpful. So in conclusion, the window of opportunity for salvage surgery is narrower in children than in adults. The time to reaction is critical. It's important to seize the golden hour before the weather becomes bad. ICP monitoring should be more widespread in very young children, and it should be very early. and ultra decompression can be very benefiting for the child, and it cannot wait. We should be it can be very rewarding surgery. We have to identify the good indications and to anticipate these situations and develop short chain reaction protocols. I thank you for your attention. You can see other videos on traumas in our playlist Trauma on YouTube, and I see you next time.